Hi everyone, and welcome back. In this episode, I'm going to be interviewing Dr. Josef Witt-Doerring, who is a board-certified psychiatrist who specializes in the accurate identification of psychiatric adverse drug reactions. Previously, Dr. Witt-Doerring served as a medical officer within the Division of Psychiatry at the Food and Drug Administration, where he analyzed emergent safety issues for psychiatric drugs and proposed strategies to mitigate risks, such as writing safety sections in psychiatric drug labels. Dr. Witt-Doerring has worked in 3 different pharmaceutical companies, 2 for psychiatric medications and 1 for oncology, in the clinical research and drug safety positions. Dr. Witt-Doerring also sees outpatients in his private practice that focuses issues pertaining to psychiatric adverse reactions. Before that, he completed a fellowship in psychiatric drug development at Janssen Research and Development, whilst also holding a post as assistant professor at Drexel College of Medicine. He completed psychiatric residency at Baylor College of Medicine and graduated from the University of Queensland's Medical School in Australia. I think you're going to find this interview very informative, and please stay tuned for the post-show. Okay, welcome, Dr. Josef Witt-Doerring. I am so glad to have you on. I've been wanting to have you on for a while, and I've watched a lot of your videos on YouTube, and you can see that you truly care about the suffering people have gone through, and I just want to say how much I appreciate them and how helpful they are for people suffering, especially when their doctors, families, and friends don't believe them.
Yeah, well, yeah. Thank you for having me. It's a delight to be on, and that's kind of all that I want to be doing right now is trying to put out as much information as possible about these conditions. You know, really the hope being that it does help people have easier conversations with their doctors. You know, it helps their families figure out what's going on with the sufferers sooner. And so I'm glad to hear that you enjoy it, and I hope it's making an impact.
Oh, good, good. So you're seeing a lot of suffering with your patients and truly the harm and medical errors that other doctors have done to the patients that come to you. How do you feel about the medical profession?
Yeah, I mean, it's certainly doing an absolutely awful job when it comes to informed consent and even recognizing risks. I mean, they're letting down. They're letting down the public essentially.
Right,
And so I don't feel great about the medical profession.
right.
And you know, I've kind of seen it from all angles. I've seen it as a trainee, as an attending physician, as a pharmaceutical physician, and as an FDA regulator. I've kind of seen all aspects of it, and all of it could be done better. And it's really to the you know detriment of patients.
Right. So do you worry about other doctors attacking you, or is it already happening? And the reason I'm asking that is because I know somebody else, one of the other doctors who went public long time ago, he was being attacked by other psychiatrists, and then they kind of kept a private list of anybody who believed as they believed in. Are you worried about that at all, or is it happening?
It hasn't happened yet, but I suspect it will happen eventually. I mean, you know, I guess I'm probably going to be looked at as a contrarian because I say a lot of things that, um, they're not the usual things that you're supposed to say. I mean, you're really meant to say, mental illness and, depression, these are such serious medical conditions and, let's not stigmatize, these suffering people. Let's not talk about the drugs. Let's not pill shame them. So I'm sure eventually I'm going to have some critics that are going to take what I'm saying in that way. But I have to say I'm kind of ready. I'm kind of ready for it. You know, it's I spent so much of my career kind of being afraid to sort of speak out about this because I didn't want to, and then eventually, I've kind of tipped over into the other side. So I'm actually trying to be as loud as possible about this. I was so ginger, I was so cautious about talking to journalists before, and now I kind of say everything as directly as possible. So I'm sure it's going to happen eventually, but
Yeah.
I'm okay with it. Yeah.
Yeah, good, good. I know even when I was starting my support group, online and, in Australia, they were asking me, well, how are you going to do it? Because this is how we do it over here. Somebody tapering shouldn't be meeting anybody who's, already off and so on and so forth. And then in the UK, they're like, well, you have children. They're going to attack you. They'll do anything to make you stop. And I'm like, you know what? We have to do it. We just have to. go for it, and now look at how many, there's so many groups and everything out there. But anyway, so what got you into wanting to deprescribe? What was the turning point that made you want to do the deprescribing?
Yeah, as for a turning point, I think rather than it being like a turning point, maybe like a turning curve, it was a slow buildup of many things over time. I mean, I came to psychiatry from a love of actually self-help books. I used to love reading people like Tony Robbins. I used to love books about psychology and philosophy, and that was really what I was into growing up. I loved it since I was a teenager, and it kind of carried me through um, my teenage years into medical school, and then um, you know I was kind of I went to a pretty rigorous prep school, and my I joke that my mom is Chinese, but it's kind of like not a joke. I mean, you have expectations that you're going to be like a doctor or an
Mm-hmm.
engineer or a lawyer. So I ended up in medical school, and I said, how am I going to marry my love for psychology, therapy, self help, all of these things into something that I'm here in medicine now, and so psychiatry was the answer. And I said, that's really interesting. Let's learn about serious mental illness, and then as I went through my training, I just saw that, essentially that there was none of those things that that I really loved. I mean, there was some of it, and don't get me wrong, I did some training on therapy when I was in residency, but the overwhelming focus on the way we treated mental illness was just biological, using drugs. So right from the beginning, I would say there was something about that um, that struck me as wrong. The overuse of medications, and I'm not going to say that there's no uses for medications. There obviously are. There's people that come out of the womb highly anxious with OCD, or people that come out with psychotic and bipolar disorders, and they need medications. So I want to get that straight. But that is not what you're seeing. Well, that was not what I was seeing. My experience on the ground level, I was seeing these things getting, uh, you know, easily just kind of handed out as if there were no problems at all with them, for minor problems. I saw a mental health system that was not set up to really help people the way that we would want our loved ones cared for. If someone was, moving town and they were, very upset and lonely and they needed some support and they were depressed, rather than, having a well established kind of therapeutic network where they could go and meet with someone and talk with them and get that kind of help, those systems have not been set up over here in the US, and so it's meds, meds, meds,
Right.
and so immediately I'm like, there's something wrong with that, and then I started hearing about the harms. I think I started looking. I mean, a lot of people don't pick up Anatomy of an Epidemic or books by David Healy and such. They kind of write them off. But I think I was already primed just because I felt like something was just off about the whole thing. And then the more I looked into it, the more I realized that all of that stuff that they were talking about was mostly spot on. I was really hesitant about Robert Whitaker's thesis at the beginning that maybe some of these drugs are making people chronically mentally ill, and the more I stay in the space and the more I treat people who are on benzodiazepines long term, a lot of people on the antidepressants who I treat, I do see cases where they've definitely have been made worse by the drug, and almost it looks like it's becoming more and more true. And so I guess that's how I became interested in deprescribing. First, I thought that the drugs were massively overprescribed, and then I just became more and more aware of the risks of the medications, and then the kind of the passion for the subject has grown as I've done it clinically.
Right. And thank God, thank goodness that we have you who paid attention and saw the need. That there was a little bit more harm. In fact, the first time I talked to, Robert Whitaker, I said to him, I believe that this pill is causing a lot of the mental illness. And I sent him the Ashton Manual and the Accidental Addict. I said, I want to send you these. And I was just so upset by everything. So, I mean, it is, I'm glad we have people like him, like you, that are stepping outside the box and really looking at this. So here's a question I want to ask you. It is so hard to hear the suffering of people trying to withdraw from benzodiazepines. So what are you doing to protect yourself? Like, how do you decompress? Because I know the effect it's had on me when I hear it sometimes, or you get that person just wrote you a letter and it all started with this minor stress and there they are on 10 drugs. It's crazy. So what do you do to protect yourself? Because, we need you to stay strong and healthy.
Sure. Yeah. So there's definitely a limit to how many people I can see. This is probably no surprise to you. You know, I start my week and my week looks nice, and I look at the calendar, and by the end of Monday, it's filled. You know, with just emergency appointments because that's kind of the nature of the patients I treat. They go into waves, and then they're really really sick, and so I have to limit the amount of people I see and make a lot of spaces in my calendars for emergencies because I
Mm,
feel like I have a panel of people who are constantly in an emergency. Again, I'm sure that's not a surprise to you, but
no.
that's what it looks like. The other thing, and this has become a lot easier over time, it's probably the mentality. We are so used to in medicine to having like drugs or treatments that we can use to alleviate suffering. And when you work with this population, none of that stuff consistently works. And there's some cases where you have to use medications very judiciously to help the symptoms of people going through this, but a lot of the times it is just reassuring them, talking to them about their options, weighing them. And for me, I had to become a lot more comfortable over time with not being able to reach for a medication and give them that and being okay with that and actually seeing over time that that's really what a lot of people kind of need and felt reassured by was just someone helping them think through the process and their options. Do I go to a hospital? Okay, what does that look like? Do I experiment with a new symptomatic treatment for my severe protracted withdrawal? Okay, what does that look like? And just kind of walking through those steps in a way um, is therapeutic for them, especially when it's with someone that kind of understands their predicament, and so that's helped me a lot. And just having that mindset
Hmm.
going into it, and not being like I need to fix it right now.
Right. Right.
Yeah.
Yeah. I'll tell you, there were plenty of times where in my head, I'd say to my husband or my mother was here, like, I feel like I have to go to an emergency room. I have to go, but I'm too sick to go. There were nights that I went to bed with my clothes on because I thought for sure an ambulance was coming. I'm sick and the sickest you're ever going to be. And yet, you can't go to a hospital. I have to ride this out. Now, remember, this is like 25 years ago that I'm going through it. So I said to them, if I go to a hospital, they're not gonna know what's wrong, and I remember one time my son's begging my husband to take me to the hospital. I'm like, "No, they will only give me more drugs. I have to ride it out to get better." So to have a doctor who understood it that you can talk to before you get somebody to take you to hospital is worth everything. That calming, that constant reassurance that we all need.
Oh, and for the family as well. I have a client right now who's very, very sick with protracted benzodiazepine withdrawal injury, and she gets it and the family gets it, that she can't go to the hospital. Sorry, her immediate family does, but the whole extended network, they don't understand, and they see how
Mhm,
taxing it is, and they keep on sending me brochures for detox facilities,
mhm,
and saying, right now there's essentially the treatment for this, very sick lady is just to essentially be at home with her family and a caretaker, and
yeah.
someone just kind of watches her while she recovers, and and it's been very challenging um, for for the parents of this girl,
Yeah.
to have
Oh,
all the
the
family
suffering.
members, oh, send her here, send her there, she needs to go and do this, and so yeah, it.
I had somebody and I did a podcast with her. I believe she went to, I think 3 rehabs. I mean, they spent the money, 3 rehabs, send her out, back on she'd go. And finally, the last rehab she went to, one of the orderlies whispered in her ear, "You're sick from the benzodiazepines." Like, finally tells her, he's like, "Get out of here and go recover." And then they kind of found me and called me, and here she is living a good life now. But it was crazy, that the 3 rehabs they paid for, you know. So they
That
don't
that is
they don't
crazy,
always help.
and each of those rehabs can be like 50 grand a pop. I mean,
Mhm.
they can be, I mean, so expensive. And And people cannot believe, when they see the suffering of a loved one that is so severe, they cannot believe that the medical system has nothing to offer them. Um,
Yeah.
and they should go, surely, surely she's so sick. If you send her to the hospital, they'll be able to help. And
Right.
it's this dark realization that dawns on people, and it is a step to healing. When you realize I'm kind of on my own. you know I am in a gap in the healthcare system where there are no well established treatments for this, and going to the hospital is probably going to make me worse. And how scary is that? But
Right.
that's where a lot of people end up, and that's kind of, for many people, that's the best place that they need to be in, because then their mindset changes, and then they can move through it in a safer way.
Yeah, I know. I know. It's very scary. So I'm going to ask you this question, which maybe some people out there are wondering, because I know you have a waiting list to see you. So of the psychiatrists that I know who are helping to do the deprescribing, none of them take insurance. So is this because insurance doesn't cover it? Because I had a doctor who was going through benzo withdrawal once, and he said that when you go through benzo withdrawal, and if you go to, like, let's say an addiction doctor, is what he said, that insurance will only cover a fast, like 30-day taper. I don't know if that's, a rapid taper, but I'm assuming people can get reimbursed through their insurance companies if they're working with any of these doctors. And why is it that they
The-
don't take it? Is it because I know the insurance companies pay for me to be drugged for 10 years, and then I never went into a medical establishment again for probably 10 more years after I, knew that it was the benzo making me sick.
the problem with insurance is that it adds a lot of administrative work, and so
Mm.
you really need the staff infrastructure in order to make it, uh, in order for you to not be bogged down, essentially, calling companies and being on hold for, 20
Mhm.
minutes here, 20 minutes there. And so, once you start bringing on people to do that, then it's, you need to see volume. And um, I think the reimbursement probably for gosh, maybe like a 25-minute visit might be something around like $135 or something like that.
Right.
Um, and um, and I mean, that may seem like a lot, but it's actually not a lot, for most psychiatrists. And so most psychiatrists, I think it's like 50 to 60% in the US at least, are doing private, because, one, they want less of the administrative oversight, the administrative burden, um, and so it's just not worth it for many people to do it in that way, which is awful. And
But understandable. It's
yeah,
understandable.
yeah, yeah, yep. And so there's me and my wife in our practice, and unfortunately there's a wait list now, and we're really busy. But the hope is that, we can turn this deprescribing, one, that you could come to the YouTube channel at least, and you could get the pieces that you need to go and do this, either on your own or with a physician. That we don't hold anything back. Anything that I discuss on the YouTube channel, I it's the same stuff I'm doing with my patients. So
Right.
there's nothing kind of hidden or, behind the veil there.
Right. I
And so
like
the hope
that.
is that,
Yeah, I like it because
yeah.
people can get a feel for you. Okay, they can bring their
Mhm.
spouse, their parent on to say, "Look, here's what he's saying about this." So I like that you put it all out there. It is nice. It's free care for them in a way.
I mean, the thing is, and the thing that I want to figure out is like, um, lots of people can take complicated things and then make them into an operation, and it's like, how do you turn what I do and what my wife does into something that could be rolled out on a larger scale with people that maybe don't have the same level of, you know, obsession or training. So, I mean, that's the next thing. It's how does this become, like a program where we can bring on, maybe, psychiatric nurse practitioners, or, new doctors, and set it up in a way uh, where it is a good product and a good service, where someone could come, and let's say had a hard time coming off benzos, I think that would be the easiest place to start. And you could put together a program of, if this, then that, if this, then that, and really kind of lay it out for someone to follow. That to me, that's the really interesting. That's probably the next thing I need to start thinking about, because
Hmm.
um, it's just, yeah, obviously it's impossible for me and my wife uh, to help all of the people that need this help, and it's just growing. I mean,
Right.
it's crazy how many people are out there. It's much larger than I ever thought when I originally came into this.
Oh, absolutely. I mean, when I think 25 years ago, there were 24 people in the support group that I started, which then I'm like, oh, maybe we'll get to 100 someday. I mean, and then it just exploded. Then came more groups, more groups. I mean, it's just grown, and it's a huge problem internationally. I mean, I see sometimes when people are ordering the Ashton manual, it's coming from, I can't even think of a country that hasn't audited there, and that's just the American version. I mean, on the benzo.org.uk site, they can get it in different languages. So you wonder how many people are ordering it. And speaking of
Hmm.
that, when people are tapering, they can dry cut, they can switch to a liquid taper, they can do compounding, they can do water titration. There are tapering strips, and now some are using a jeweler scale. Is there one form of tapering you like more than another? Or do you just see how a patient's doing and you adjust accordingly? I mean, you can prescribe, in different ways. But in fact, when water tapering became, the new thing, Professor Ashton actually liked it. So how do you feel about all the different ways of tapering that are out there today?
Okay, yeah. So my views change on this, and but for your standard patient that comes into me, I tell them to do cut and hold, 5 to 10% reductions, and then your first cut, you want to give it 4 weeks, I think, and then you shorten it. So if, let's say, they had symptoms for 7 days or something like that after their first cut, okay, well, maybe you only need 2 week, 2 weeks between dose, 2 weeks between drops, because I like people to be symptom free for a week before I do another. Well,
Hmm.
not symptom free. I like them to be back to their baseline for a week before another one, before another drop. Um, so I like cut and hold first, just because it's simpler. But there's two dimensions when it comes to a taper, at least how I think about it at the moment. One is the duration between drops, and that's anywhere between 2 to 4 weeks. And at least the way I think about it is I will shorten or lengthen it so that the person is back to baseline for 7 days, more or less. And then the next domain, the next part of it that's important is the size of the reduction. And so, size of reduction, how I like to assess that is, does the person's level of functioning stay the same? Because I don't want to do a reduction where for those 7 days the person says, I had to take like 3 days off work, I couldn't leave the house,
Hmm.
I can't cook. That reduction was too big. So that needs to I will cut it back. We'll go. So if that happens, we go back to the previous dose and we do a smaller cut, and then we reassess. And so I like to adjust the size of the drop to to anywhere where the level of functioning remains the same. I mean, the symptoms can be worse. You can be suffering, and a lot of it is suffering. But I think the level of functioning needs to be more or less the same. And so when I start thinking about someone doing like a liquid micro taper,
Hmm.
it's usually that next step. So we've tried cut and hold, and when we've been doing cuts, each of the small cuts, just it's still bad. So 10% cut, level of functioning ruined. 5% cut, level of functioning very bad. 2% cut, level of functioning still very bad. That's when I'm starting to say, okay, this person needs a micro taper. We need to do 5% over the course of a month, and then each day they're going down, whatever it is, like 0. Like a some tiny fraction, a 30th of that 5% drop. And that's when I would go to a liquid micro taper. Or yeah, or you can do a micro taper with a jewelry scale and a nail file. Um, and I guess the other thing is when I do cut and hold, it also depends on what's easier for the person. I mean, some people like to go to a compounding pharmacy, and if they have access, I think that's great and it's really
Mm.
easy. But other people just use the pill with a nail file, and they'll just, you know, take off the percentage of the pill uh, each day and do it that way, and that's fine as well.
Okay. Yeah, I mean, it's funny when I first was in touch with people over in the UK, some of them were doing just the nail file. Okay, so I'm going to do one stroke, and then I'll do two strokes. I mean, this is what you have to do to get off. So in the Ashton manual, it suggests switching over to Valium because it's longer acting. And Dr. Reg Pert, who ran Victims of Tranquilizer, and he was a victim himself of them in the UK, who Professor Ashton turned to for a lot of her advice, also believed in switching to Valium versus Clonopin. He wrote a paper on it. And yet we see people switch right back to their original benzo if they didn't feel well when they switch over to the Valium. And they tend to have a better control of it when they go back to their original drug. Others were successful in switching. Some aren't. What is your opinion on switching? Because I've been pretty public, even though I loved Heather, I loved everything she did. I mean, because we got so big over the years, you could see the ones who did wonderful going over, and those that it just Valium wasn't good for them. So, I mean, I just believe it's kind of got to go with what's best for the person. What are your thoughts?
Yeah, I'm happy to be very public about this as well. I never recommend people cross over to Valium as a first line. I think it's in general, it's safer to dance with the devil that you know. I've made
I
people really, really sick crossing them over to Valium, like totally messed up their taper, put them into severe waves, and then just been like very confused and stuck in a place where they're half transitioned over to Valium and half on their original drug, and they're stuck and they're like afraid. And
mhm,
so that only had to happen to me a couple of times before realizing that, hey, not everyone needs to go over to Valium. I'm much more I'd much prefer someone be on the original drug. So, for instance, if someone comes to me on there on Xanax XR, 1 milligram,
mhm,
the first thing I'll do is just put them on the instant release version and just spread it out in maybe 3 doses or 4 doses throughout the day, and then I'll taper them from that. So um, that's that's essentially kind of hopefully doing the same thing that a Valium crossover would do, a more even spread of the medication throughout the
right.
day. And so I try and do that. In some instances, someone will come to me and we've already tried that, and they're still having a lot of, I guess, interdose withdrawal. They're on the original drug, we've spread it out, they're still having a lot of interdose withdrawal. In that person, I may try and start introducing some Valium to see if it helps. Um, but that would be like this second line thing that I'm doing really to specifically treat interdose withdrawal. My wife, she likes to use Valium in the evening. She's had a lot of success doing that, maybe just swapping out an evening dose. And so she might have someone on a few doses of Clonopin during the day and then Valium overnight, especially if they're having sleep problems.
Mhm,
And she's had some success doing that. But it's really like individualized.
right.
But overall, I'm just going to say, yeah, I think be careful doing that Valium crossover. That can be really. I think you can make people worse. And sometimes they cross over and maybe they don't get this massive wave, but they become incredibly lethargic and slow cognitively, and that's really tricky as well.
Right. Yeah, see, I learned actually more with Dr. Pert. He would say, yep, they're going to get very lethargic, let them hold for a good month till they start to stabilize. And I used to think, thank God, I controlled myself better with Ativan. I always used to say it was the devil I knew. I knew how to control it. And I know if somebody gave me the choice of switching over to Valium, I think I would have just stayed with Ativan. I've seen, like I said, so many go over to the Valium. They hate it, and they'll jump right back. They don't even wean back. They jump right back to, let's say, if it was Ativan, and now they're like, okay, now I got it. I got to go slow. I got to keep it level in my body. So I'm glad you said it because there are some people think, oh, I have to switch over to Valium. So it is. It's very individualized. It might work for one, but as with anything with this whole process, what works for one isn't going to work for the other. So I have been pretty public about that. Now, here's a question that I'm going to ask. And as much as I'm learning that I shouldn't even have to ask this question, I know that it has to be asked, if a person is drinking alcohol while tapering, because I'm shocked to learn how many, when you talk to them, all of a sudden, like, oh, well, I drink every night. I'm like, no, you're not supposed to be drinking. And sometimes they're not even telling you for a while, and then you discover that. So, and I know once they're off, easy for me to say because I don't drink alcohol, but Dr. Pert was adamant that there was no alcohol for 3 years after you come off of benzo. So, what are your thoughts? And do you even have to ask somebody now, like, are you drinking alcohol? Because, and I tell them if they are, you can't just start tapering that. You got to wean off your alcohol first. So, I won't give anybody
Mhm.
tapering advice. I'll say to them, well, we'll talk about it, but I am shocked how many are drinking.
Interesting. Yeah. So, um, ideally, everyone should not be drinking at all, or using any caffeine, or and this happens as well, using any recreational drugs
Hmm.
during this. And that said, I also have patients who are drinking and who are tapering. I mean, it's not excessive. It's not excessive drinking. They'll, maybe we'll have a glass or two a week, and for them at least, it's okay. It's not excessive, and it
Hmm.
doesn't seem to be making things worse. But any kind of heavy drinking, I think, is not good. If I get someone who has tried to taper and they're drinking heavily, and they're doing it because they're in withdrawal. Usually, I get them to stop drinking, and I actually increase their benzodiazepine, and then uh, because a lot of times the drinking is triggered by being, they can't handle the level of the withdrawal. It's
Right.
it's going too fast for them, and they're doing it. And for me, I'd rather them be on more benzo and not have this very unstable kind of alcohol going in and out of their body. And so we go up a little bit, we get them stabilized, and then we come back down,
Hmm.
completely dry in a very gradual way.
Oh, good. Yeah, that's smart. See, because you can prescribe for them. So the ones on the groups, and they don't have a doctor, they just got their regular dose of benzo, and then they're drinking. So that's why I'm like, no, you got to get off the alcohol first. But again, easy for me to say. And I also have never had coffee or tea. So I'll say to them, if you're going to drink a lot of coffee, can you just have one in the morning? And I don't, believe in doing all the artificial sugars. I think that can really affect people. I had somebody, we had become very close, and he'll tell you he was 110% recovered. And all of a sudden he's a mess. And I'm like, well, what have you done? And he goes, well, I'm drinking this Propel water, and I don't know what Propel water is. And then he called me back and he said, oh, my daughter just looked and it had sucralose in it. And just from having the sucralose, he was out of his mind. So I'm like, okay, just stop drinking it, flush yourself out. So different things can affect people, that put them back in
It's
hell.
Yeah, yeah, and this is a message for the people out there with protracted withdrawal, and it's even after you've recovered, or you feel like you're 90% recovered. All what I've noticed is that it just means that um, you're mostly able to regulate, the injury. I mean, the injury is still there, but the capacity for your brain to regulate it has gotten to a level where there's not a lot of suffering. But still, it's very easy to knock that system out of balance. And that's why you hear stories about people who, they'll drink a cup of coffee or go out for a big night drinking. They're like, oh yes, I'm recovered. I can go back to my normal life, and then they'll trigger a massive wave, because as soon as you throw in some of these external things that upset the system, I mean, that little bit of like regulation that your brain has been able to put together to suppress your symptoms, it's no longer able to handle it once those things come in, and it is really heartbreaking. I spoke to someone on my channel not long ago, Brian Belts, and he was a young guy with a benzo injury, and he was talking about how excited he was when he thought he had recovered, and he'd used some recreational drugs, and essentially it threw him into a wave, which has been ongoing. And I mean, it's just, yeah, it really is heartbreaking, especially for those younger people who want to go and be be in their 20s, and do things, and
Yeah.
do what their friends are doing. But I mean, the advice is, after you've recovered from a protracted withdrawal injury, yeah, at least a year. If you could do 3 years, that's
Yeah.
even better. I mean, it's just keep things in the same place just so you can really solidify the healing.
Right. I agree. So,
Yeah.
and again, we're not saying you can't ever do it again, but he was, Reg was adamant for 3 years. He felt the brain really had to heal. I mean, I had a young guy. I was actually become close with his mom, and he called me up and he said, I'm turning 26. I just want to go out and have a couple of beers. I'll have organic beers. And I'm like, I can't tell you to do it. I mean, I don't drink, easy for me to say. And he did. He went out and he had just 2 organic beers. That's it. And set him back. I mean, he's fully recovered
Mhm.
now, but yeah, it's you'll have some that will say, "I'll never drink again," and even Heather in her manual says that you could have a little drink. But I know there was one of the organizations in Australia years ago when the manual first came out. They're like, "Oh no, no, we will not be recommending her manual to anyone because she recommended you could have a little alcohol." And there was something else that they didn't like, one of the meds she said you could take, and that's just being a little hardcore. But, people have choices in life. And to me, it's just easier to not do those things when you've worked so hard to get your health back. And then speaking of health, okay, so when you're working with somebody, do you have them change anything with their diets? Like, do you have them use any supplementation, or depending on where they are in their health, do you recommend them doing some exercise, or what are your thoughts about using some additional therapies like acupuncture, saunas, breathing techniques, or anything to assist? Or do you just not even get into that with them?
Yeah, so I some things I get into, some things I don't, and the reason I'm not getting into some things isn't because, oh my God, I think they're terrible and they're a waste of money. It's really out of just not knowing. There's only so much I can know from my
Right.
background, and so here are my thoughts on diet. Um, Diet seems to work really well for some people. The amount of people who I know closely who have gone on a keto diet or who have done an elimination diet and who 3 months later come back and just say, "Oh my God, I feel so much better," is growing steadily. And so I think everyone, if you haven't tried to at least cut out gluten and dairy or go keto, that's something to experiment with. That really seems to make an impact on people. And I don't think it has anything really to do with like withdrawal, like the pathology underlying withdrawal. It just seems to make some people feel better. I mean, I personally, I did an elimination diet and my back pain became much less. I just think there's something maybe just in general about simplifying your diet and getting rid of things that are associated with inflammation that may just help globally with health. So I always tell people that I think an elimination diet is a good idea if they have the bandwidth for it, if they're healthy enough to do it. um, as for other supplementation, again, it's just not something that I'm really aware of. I mean, some people take magnesium. I think that has like a direct effect on the brain. It seems to be calming for some people. For others, it can be really, and then for some, it can be very hard to stop later on. And people just do these things, and I kind of carefully just oversee it. Acupuncture has definitely been helpful for some people. So has physical therapy, especially if they're protracted and they have protracted withdrawal and they have a lot of the muscle tightness and things like that. But I probably the main thing I would. And then coming to exercise, I think exercise is really great. But again, for the people with the protracted withdrawal injuries, exercise tends to be another thing that can upset the balance. Especially when people are coming out of it and they're getting some improvements and they're having some days that are okay. If they go on like a long walk or walk up a couple flights of stairs, they can trigger like a mini wave that goes on for a few days. So again, it's this terrible thing where okay, you've regulated your brain to a point where symptoms are reducing within this extremely narrow range, and then even something as seemingly healthy as exercise, it just throws it off and you feel unwell. So with the protracted withdrawal group, exercise is something you just want to pace yourself into. You want to do a little bit, hey, how do I feel? Then a little bit more. And you need to kind of find your limit. But in general, yes, exercise is good. You just have to be careful if you're in that
Yeah,
protracted group.
I agree. I even when tapering, I learned myself the hard way. I was doing smoothies and healthy soups, and I'm exercising, and this is while I'm tapering. And I got myself so sick, I didn't exercise for years. So I always tell people everything should be gentle. Everything we do for the body, gentle, slow, work your way up slowly, everything. So yeah, I agree with you there. And as for diet, there are some out there, they're lucky if what they can get in a day. So is it mandatory you eat healthy? No, but I don't ever want to be sick again. And not that I don't cheat, but I try 90% of the time to eat well. My son might disagree with me there if I want to make a treat, but um, I just don't think people have to think so rigidly, but absolutely removing the gluten and the dairy. I usually recommend like the Whole30 because there's so many recipes online. Keto, I see them doing it and they feel great, whether they want to do that. There are choices out there and we all have choices to make. So I agree with you with all of that. So,
Oh,
but yeah.
couple final comments about diet. I'll just say I have seen people get worse on keto as well. And then also, I want it to be really clear. I've seen people completely heal with a regular, normal
Hmm.
diet as well. So,
Right.
I mean, these
Even
are
a
just
junk
like
food
little
diet.
bonuses.
Yep.
Even a junk food diet, even a junk food diet is better than eating nothing, as well. So, I I would just say it's the diet. I know it's really hard. It can cost a lot of money. It is not essential. You will still heal without
Hmm.
changing your diet.
Yeah.
Yeah.
I agree. I agree. But if I can get somebody who's just starting to taper, like even my friend, I did a podcast with her, and I'm a firm believer that if we can get them before they start the taper, if we can get them to start eating healthy first, establishing the good habits, a little bit of exercise, get the support, get your support around you, get ready. I think they have, an easier time. Like, you don't just get up and run a marathon. So you'd prepare for it. I mean, so do you ever get somebody who's before they start so they can get everything lined up, like line up your people, line up, what you want to do, even to learn a breathing technique before you start? Have you ever had somebody, or they're always coming to you, they're already in crisis?
I was just thinking that, yeah, they're in crisis by the time they find me.
Okay.
If I had someone who wasn't in crisis, who just came to me on a bunch of meds and was just like, "Hey, I stumbled upon, anatomy or something, and I realized that actually the risks of these drugs are way more than I expected, and I want to come off." I would suggest something like that. I think that's great to kind of get those healthy habits locked down before we start shocking the system.
Mhm.
It's just not how people tend to find me.
Right, right. They get you after they're already in a disaster. So one thing that you
Yeah.
must see a lot is people must come to you diagnosed with so many different things, and then as you're helping them get off, and you see them getting healthier, and all these issues are just going away. Have you seen anything yet so far? What things that they were diagnosed with, and it's all gone?
I mean, it's the main thing would be like bipolar disorder. I mean,
Mm-hmm.
this is mainly an issue for the antidepressant folks,
Mm-hmm.
and or the people who have been like experimenting with cocaine or methamphetamine and such. But they frequently come with bipolar diagnoses. This happens to a lot of people with PTSD as well. Um, any kind of type of psychiatric symptoms where people can become very emotional, highly irritable. So think depression, like anxiety and PTSD, and maybe even the personality disorders. Often they end up on medications, and then they kind of eventually something flips, and they get diagnosed with a bipolar disorder. So um, that's probably the most common one. I mean, the other one with the benzo injury folks is that a lot of the times they get diagnosed with those hysteria type conditions where they
Mm-hmm.
say they have like a functional neurological disorder, where it's like essentially, the symptoms are, psychological manifestations of their distress, or it's called illness anxiety disorder, where they believe, yes, maybe some of these things are true, but the way they're describing them is so exaggerated, and it's because of their mental illness. So that's that's what happens to a lot of people when they interact with the healthcare providers who cannot recognize the pattern of symptoms that they're presenting with, and so the only way they can understand it is through one of these kind of waste paper basket diagnostic bins. And so once they meet with me, I just go, no, you have a brain injury, you have a protracted withdrawal injury,
Hmm.
and this is what it is, and and such. So yeah, those are the two I see a lot of.
Okay. I have a couple of crazy things I want to ask you. So,
Oh yeah.
over the years, we have people, we call them the non-sweaters. So, these are people that have lost the ability to sweat because of a benzo, and some couldn't sweat from the beginning. So, the non-sweaters. So, when we find that out, again, this is 25 years of learning. When we could get them to start sweating, in fact, even one of my moderators, she lived in Florida, she could not sweat. So, and 7 years later, she's still sick. And then we find out she doesn't sweat. So, as we get them to sweat, they start to feel better. Have you noticed that in your practice at all? So, I'm starting to ask people now, do you sweat? And it's amazing how many of them, like, no, hardly ever, like ever. So,
Um, I see a lot of sweating dysfunction. People. Well, actually, the truth is, I don't ask about it as much as I should, but it is something that I've read a lot online,
mhm,
about dysautonomia symptoms. And so when I say dysautonomia, I'm talking about a very varied heart rate. One that you could be sitting quietly, and then all of a sudden you're at 150 beats a minute. And this is not a panic attack. I mean, this is just you feel your
mhm,
heart just randomly racing. In the absence of any kind of stressor. Sometimes the blood pressure goes all over the place, and then the other symptom of dysautonomia is the sweating. And that people can stop sweating, or people can start sweating excessively.
mhm,
Um, and so this is so weird because okay, so it happens in the folks with the antidepressant injuries. It can happen in the folks with the benzo injuries, and it also happens to people with long COVID and also with COVID vaccine injuries.
mm,
And that is just the most bizarre thing in the world to me that we can have so many different types of conditions that seem to cause this injury to the autonomic nervous system, which is it's the nervous system that controls the parts of our body that we're not conscious of, heart, sweat glands, blood vessel dilation. And so I mean, that's just something that just astounds me, how many different things can mess with this system. But
right.
it's something that I need to ask a lot more about, because yeah, it really fits with the whole idea that these benzo injuries, I mean, it's really global neurological damage
Mhm,
affecting multiple parts.
right. So, and
Yeah.
even talking to a healthcare professional, he said, look, if they can't sweat, let them start slowly, just putting their feet in some water with Epsom salt, to get them to start sweating. But I know with my moderator there years ago, that started to, her son would take her to the beach, in the sun, and she would sit with her feet in the water, and she would bring a spray bottle. She was trying to get her body to sweat. That was the start 7 years later of her starting to finally get rid of those protracted symptoms, that she had.
Well, let me
So,
ask you this: what do you think about like sauna therapy? Because that's a way to get people to sweat. Has that
so
been helpful to anyone
So
from your
actually,
knowledge?
I've gone back to a few people that don't sweat because as I've been researching this lately, and some are actually going to go do the sauna. And even in my own case, so I would sweat. I was sweating profuse. I'd go to bed with my hair straight. I'd wake up with it curly. But in my trying to recover, my cousin got us a free week at a female place to go, a fitness place. I don't know that my own cousin doesn't sweat. So she goes with me for the week. We're going into the sauna. We're trying, we do the steam. So we're trying to do that Swedish thing where you do the cold shower, go into the steam, come back out, cold shower, go in. You do it 3 times. In her bringing me for the week, she starts sweating. I'm like, you never sweat? She goes, never. That brought her body to sweat. And she was like, I can't even believe she didn't even know she felt sick from not sweating. So, yes, we do see that. Now, here's the other one I'm going to ask you. So over the years, and I'm really just starting to, I put these questions down if I'm talking to somebody now, if they have a gallbladder. And so again, talking to the natural health professionals, I said, what these people that don't have a gallbladder, that what should they be doing? And they said that they should be taking a digestive enzyme with ox bile. So if you don't have a gallbladder, it should be digestive enzyme with ox bile. Has this come up at all? Like, are we noticing that? Because even though everybody says it's an organ we don't need, was starting to realize it had a purpose. Is it making the liver work harder? And some people wound up in the benzo groups because they had the gallbladder out, and then they had anxiety and they got put on benzo. So that's kind of something I'm having them. I know I had somebody had to do a survey in one of the groups. Did they have a gallbladder?
Um, I have to say, you have just put this on my radar. It's going to be a pattern I start looking for. But I don't have anything to really report on in terms
Okay.
of whether that's my patient population is has a high amount of people missing gallbladders or not.
Right. It was just like something that you start to notice, wait a minute, this one doesn't have a gallbladder, and wait a minute, that one, so does that help assist the body? So this health practitioner, two of them I've asked, said yes, digestive enzyme with ox bile. It has to have ox bile in it. So again, we're not telling anybody to run out and do it if you don't have a gallbladder. It's just something I think we should all be looking at too. Um, so
Mhm.
in the GAPS diet, Dr. Natasha Campbell McBride's book, she talks about the gut, the gut, the gut. So what are your thoughts about working on the gut in general, or even slowly assisting the liver? Not, I don't believe in detoxing, because again, anything with us has to be done so slow. I know myself at 5 years off, I was still sick. I'm running a group. People are getting better before me. And I'm thinking, oh, I'm doing all these right things. Why aren't I getting better? When I have some functional medicine tests done, and not that I believe everybody has to run out and do that, because we don't have to. My gut was a mess. I really couldn't tell. My gut was a mess. And genetically, my liver, I wasn't born with everything you have. So everything I did was done slowly to heal the gut again. Everything for the liver, I was very nervous to do that, was done like at a snail's pace. And that's what finally brought me. So for me, and again, that's me, time wasn't going to heal me. I needed a little intervention. So have you, I think it's, I don't know. I mean, we know these drugs are amongst the drugs that harm the gut, and not that it's going to harm everybody, because we look at some that just get off without a problem.
Sure. Yeah. So I mean,
What do you
again, this
think?
is getting maybe yeah, it's a little bit outside of really where I specialize. I mean, the extent to which I think
Right.
about gut health is really the elimination diet, and it's just the idea that over time, people don't realize that they may be ingesting foods which are causing bacterial overgrowth or maybe inflammatory in some way, and that there's so much connectedness between the nervous system, the enteric nervous system, and the brain that maybe for someone who already has a disordered brain, they have a protracted withdrawal injury. If you can simplify what they're eating and kind of get rid of things that are causing inflammation or bacterial overgrowth, you may be able to reduce the overall number of, I guess, impulses coming from the gut and going into the brain. And I mean, this is just speculative, and I just assume that maybe if there's just a lot of activity out there, it's just creates more disorder in the nervous system and in the brain, and maybe the symptoms are more intense in some way. Again, this is just me speculating it, but
Right.
that's how I think about
Right.
healing the gut.
Right. So there are a lot of people, when we talk about the brain, a lot of people, our eyes are affected. I know mine were. Their thought process is off. A lot of them are talking about black brain. They feel like their brain is dying. When somebody's tapering, what would you do if you had somebody like that? Their vision is affected, or they're seeing things differently. I mean, it's a process to heal. I didn't have that. My eyes were affected, but I didn't feel like my brain was dying or that I had black brain.
This black brain thing is really interesting because I had someone reach out to me from Belgium recently explaining essentially that, just that I feel like a piece of my brain is dying. I've also heard it feels like parts of my brain are frozen, and I really didn't think much of it, but I mean, is this some kind? Is this something that people are experiencing? I mean, what's your like? What does black brain mean to you, Geraldine?
I,
What have you heard from people? Yeah,
so there were like three young girls now, and I know the one from Belgium that you're talking about. And so again, we have
yeah.
three young girls right now, all trying to explain it the same way. And when one heard that the other one said black brain, yes, that's what it is. And all are tapering. That's the thing, all are tapering. So it's the first time I heard that. And and I'm not sure if they're all having the visual. I know one is having severe visual issues, can't be near any light. I mean, I even had to wear sunglasses in the house, but this goes beyond that. So to me, it's just where, Heather Ashton used to say that we all have a weak point, so is that their weak point? Is that their brain, that they're all very logical, they can think, they can talk, but they feel like their brain is dying inside there. It went black. So hard for me to say when I didn't experience it. But yeah, I mean, there's 3 young girls right now experiencing it. And I'm sure there are others. They all say the same thing. Is something with the eyes, the migraines. I don't know. You try to figure everything out, but I'm not sure. I was just wondering if you had any answers, or it's just, again, it's
Yeah.
a
Well,
symptom and they got to
I've
get
got
through it.
someone. I got someone on my panel, not this this girl from Belgium, but like another person who changed, who was doing a swap from one benzo onto another one. She already had a protracted withdrawal injury, and she described the same thing. It was just like while she was swapping, it was like a part of my brain died. And then she said, and I just felt like I was becoming psychotic. And like all of the
Right.
symptoms that happen to people during this, I'm hearing it and I go, man, I don't even understand like what that must be like. But then you notice these similarities, and then this girl from Belgium says, I've got, part of my brain has died, and I'm just like, wait, is this just like a strange new symptom that's, clearly very hard to describe, but I mean, I'm interested in it. I mean, if anyone listening to this has a similar experience that fits with Black Brain or something like that, could you just email it over to me at jwd@wittdoerringpsychiatry.com, because I'd like to hear more about it. But
Yeah, good.
the other thing is the vision. Oh, yeah. So the vision stuff that I'm the most familiar with is really just light sensitivity. I mean, it's people I've heard a few things, and a lot of this is very similar to what is in my interview with Kathy Donald. It's the malpractice one on the page, and she would
Hmm.
talk about a few things. One was just severe light sensitivity to the point where she would need to put a piece of tape over the green illuminating light on her microwave in the middle of the night because it would be so irritating to her. Driving was hard. It was distracting. It just felt like everything that was kind of coming into her through her eyes and her ears was just overwhelming. She also experienced an inability to gauge depth well. She, could not for the life of her park her car in a space. Would often fall, kind of reaching out to grab things or to move around things. So lots of visual things can happen during this protracted withdrawal period. And I guess the other folks, which is really sad, is the people with PSSD, and they develop something. And this is the antidepressant people, not the benzo people. They develop something called visual snow, where it seems like their image, their vision just becomes incredibly grainy. I haven't
Hmm.
had any benzo people tell me about that,
Oh
but
yeah, no,
there's a
no,
lot of
yeah,
there's a lot of visual things that can happen with these drugs.
right. All right,
Yeah.
let's get into and I had sent you an article, the one from 1961, published in the Journal of American Medicine about benzos in a woman's menstrual cycle. So the first year that we testified at the Massachusetts State House, just about every woman there had either a hysterectomy, multiple DNCs, or lost her menstrual cycle until she was off, and it would take a long time to get it back. I saw my periods change while on Ativan. I went from perfect periods to bleeding 3 weeks out of the month. And when I had the hysterectomy, I asked, when I woke up, what was wrong with my uterus? And he said it was in perfect condition. So we see in the groups now that as women are tapering, they're getting their periods are normalizing. Or when I talk to someone who's off, I always ask that woman about her menstrual cycle. And just about all had issues. So are you seeing that? I mean, I always do ask a woman that because, some are very upset because they've aged out, they can't have children, or the ones that had hysterectomy, some of them still mourn it. I mean, that's, another tragedy, happening to the women.
I mean, this is just another example of you really teaching me something, because you're boots on the ground, you're interacting with a lot of people, and you're noticing these patterns. And it's not a part of the body that I've been asking a lot of questions about, and I will need to do so. I mean, the one part I can relate to is the several conversations I've had with a lot of women in their 20s and 30s who are really worried about whether they're ever going to have children, you know, because they're so disabled
Hmm.
um, from this condition. And so, but that's it's not so much of a point from a point of you know my physiology has changed and I'm not having periods. It's more from I'm so debilitated from this. How could I ever care for a child? But yeah, I'm gonna have to start asking more about that.
Okay. So as we talk about, because I always at the hearings, I always mention this because it's so upsetting to me. But in Holly Hodman's documentary, As Prescribed, you see some of the doctors testifying against us. And you testified in favor of Benzabil, which I so appreciated. That particular year was done via Zoom. So none of the doctors that usually testify against us showed up. I wish they had, because it would have been the first year they would have had doctors testifying in favor of the bill. And it's sad that we even have to turn to legislation to have a bill about informed consent, short-term reason, short-term prescription, symptom-guided tapers. And the main thing is we want to protect long-term users. So personally, in the United States, we probably have more scientific information on benzos than any other country, yet no one is listening. So what is your feeling about legislation? And, what are your thoughts about Holly's documentary? Because you did get to see that, where you saw them talking against us.
Yeah, I think I mean, first I think they're wrong. I mean, I've I came from a place of handing out antidepressants like a lot, when I was in internship and kind of like figuring it out in second year and then kind of really changed. And having really thought about the risks of these medications, I would totally for legislation that would make people sign a piece of paper, whether if it was for benzodiazepine, it says, you understand that this could make your anxiety worse in the long term. Yes. You understand that you could have withdrawal symptoms that could last, for years later. Yes. You understand that you could have neurological damage by taking this medication, that may take years to go away. Yes, with the even, I know this would be easier for the benzos to get past, but even with the antidepressants, God, they have so much potential to ruin people's lives and their sex lives and the PSSD and the protracted withdrawal that happens there. Even for the antidepressants, I think someone should sign because they should sign a piece of paper that they acknowledge those risks because I really believe that like only 5% of the people who are currently taking these medications would continue to take them if they really knew how bad some of these risks were. So, am I for legislation for this? Yes, because I mean the doctors are not doing a good job telling patients about this, and so when they can't do it, yeah, please government step in and put this risk mitigation in place.
Right. I mean, Holly's film showed exactly. I mean, these were doctors practicing for like 30, 40 years, and they're saying we've never seen it. It was, and to be there and to hear them saying it when they're in a room filled with people who have been injured. And do you know that they've never heard anybody else speak except for me because I go up first, then they were coming behind me and they would leave. One did stay 1 year and they leave. They don't hear what anybody has to say, even a mother's there whose son killed himself, and then another year they were asked to stay. They were specifically asked to stay and they still walked out of the room. They've never heard our stories, which is sad. And, so when Holly brought that to light, just what we're up against here, that was pretty sad. How did you view her documentary?
It was great. I loved her documentary, and I think it was good to kind of see that part of it in particular. And it's just, I mean, it's a snapshot of what I see every single day. All of those
Right.
patients are kind of like my patients. Um, and and yeah, so I loved it.
Yeah. Oh, good, good. Yeah. I mean, it's bringing the message out there. It's showing what we're up against, and there was so much that goes on when you're there. It was amazing, and I hope you'll testify again. Garrett, the bill was filed again, right? We're just waiting for a date. We're waiting for a hearing date, which could happen from now till when? Until next February. Okay, so we'll be definitely letting you know.
I'll be
You know,
back. I can tell you that now. Yeah.
good, good.
You know, so
And they're now going to be doing them totally via Zoom, right, Garrett?
You'll have the option.
We have the option to be there or do it via Zoom, which for everybody it's nice to be able to do it via Zoom. And it's sad that
Mhm.
the opioids became such a nationwide problem. And I believe the benzos are an even bigger problem. Like, how do we even bring attention to it? There's so many books, documentaries, YouTube videos, scientific articles, websites, symposiums, all warning about these drugs. And yet the professionals aren't even listening or taking us seriously, because with the opioids, you hate to say it, they're dying. But with the benzos, it's like we're crazy. I walked in and
Yeah.
I was a normal, healthy, working full-time mom. And because I had a baby with an infection that I don't know I had a uterine infection after childbirth, that then came the benzo and all that. Like, what do we do? I mean, you can't. So I'm just saying, this is a huge nationwide problem. And I know even when I got to speak at the governor's meeting, I was asked to come back and speak. And when they heard my story of my niece who, went into going through a divorce, drinking, goes in to come off alcohol, comes out on Xanax, which is worse, gets in a car accident, she's given an opioid, and she dies at 30 years old, leaving 3 little girls behind. And so it's like, this is bigger.
Mm.
She should never have walked out of that rehab on a benzo, number one. But it's just a lack of understanding. There's so much out there now, and I don't even know how we fix it after all these years, but we could do this for hours. There's so many questions. But before we end, and I had so many things that I wanted to talk to you about, akathisia and DPDR. I don't know if we could just spend a minute on that. Akathisia, which is so
Mhm.
hard for people, and DPDR, it's hard enough when they're tapering, but when they're off, have you found anything that can help with that, or is time the healer? Again, in speaking to a couple of natural health professionals, they had some ideas, and it's funny when they mention this one thing, it's what Dr. Perts said he was looking into, which is acetylcholine, which then you could take phosphatidylcholine, I believe it is. But that's something we have to research. So I feel like we have to be looking at this. But what do we do for those with the DPDR and the akathisia?
Um, so DPDR, um, that one I don't know
Yeah, I don't either.
anything really helps for the
Yeah.
DPDR. That's to me that's mainly supportive, and it's just kind of helping them recognize the impact that it's having on their lives and in their relationships, and maybe explaining what that state of being is like to their care team. Because it can be really disorienting for, like a spouse to be
Hmm.
married to someone with DPDR and who's so disconnected, and just helping them recognize what that is and what it's like. For the akathisia, I mean, I don't have that, much better answers. I think that, I mean, time is the thing that heals that. But
Right.
I mean, and I've kind of talked openly about this. I mean, I've had some people, I've had one guy in particular so sick that he ended up on fentanyl for a period of time because his akathisia was so bad and he stopped eating. And we had to do that for a few months. So,
Hmm.
I mean, that's obviously a really heavy drug and one that causes dependence and could make people, stop breathing essentially if they're also on benzodiazepines or even on its own. So, really scary drug to use. But sometimes you're just essentially forced. But other things that people can try very judiciously and always at, lower than the starting recommended dose, especially if they have a neurological injury. Clonidine seems to have helped some people. Metazapine at very low doses might help relieve symptoms a little bit. So does propranolol sometimes. But these things that they're all so hit and miss. For
Right.
everyone that it like helped, it's also caused a setback for
Right.
some people.
And we do know that time does help. It's just it's a hard
Yeah,
thing to tell people. Yep, time is going to help you. I mean, I have so many.
yeah.
We could stay on for like another hour. And I
I'm
know your
Well,
time,
I
my
want to say
time. Yeah.
that's okay. I want to say one more thing is
Yeah.
I these are the people that find me the most. If I think about the people that beat their way to my door, it's the people who have severe akathisia, because nothing is like more frightening than that. And we go through this stage and we get to the point where I'm like, well, we can try, some opiates, or we can try some, uh, morphine, or we could try some fentanyl if it's really getting that bad. And it's almost like getting to that point of saying that to them is the point where they go, oh, there's nothing really that can help me, it's just time. And so I walk with people through this like panic of like, how do I even cope with this? And then when they get faced with the fact that, yes, maybe you could do it, but it's with, God, fentanyl. Like, who wants to be on fentanyl long term? I mean, it's just, they just go, I'm gonna find a way through this without it, And so that's a very common thing that happens in my practice when I work with these folks. I show them the options, and they go, I will do everything I can to not take that fentanyl and just find a way to survive while this heals.
Right, right.
Yeah.
So before we end, is there a special message of hope that you would like to say to those around the world that are suffering? Because I'm sure they all wish that they had you as their own personal physician.
Um, I think the message of hope would be that the information to do this work safely is already out there. It's in places like the Ashton Manual, or it's in places like Inner Compass, and the Withdrawal Project, and all of the really good nonprofit organizations that are getting this out there. So the information is there. Some of it's on my YouTube channel as well. And the main thing is time. I mean, for most of these things, we especially the protracted problems, is we're just talking about neurologic injuries that recover over time. So at the lowest common denominator for this thing is, once you're doing a safe taper, that is, once you've figured that part out, the main thing you need to do is just make it through the day.
Right.
And that makes the whole thing just simple. Just do everything you can to make it through one day after another, and people recover substantially to the point where they have meaningful lives.
Right, right. Well, I can't thank you
Yeah.
enough for doing this podcast and for your understanding and your believing those of us who have been harmed, and for helping them. And I can only hope that more physicians will follow in yours and your wife's footsteps.
Well, thank you so much. It was lovely talking to you.
Great. And then I hopefully we'll do this again, because I know I'm going to have more questions at another point. Thank you, thank you, thank you.
I'd love to come back.
Boy, Garrett, I really loved that interview with him. And we could have gone on, I would say, another hour. I actually had more questions, but I know we had a time restraint.
Yeah.
Mainly because of you. You had a commitment I didn't know about, that you had to go. And we also had booked 90 minutes, and, there's setup time and whatnot. Right. What did you think?
And we're now recording this like 36 hours after the interview.
Right.
Which is the first time we've ever done that. And that's only because you had a commitment that night. We both had commitment. You had to go to the State House the next day. I was busy the whole next day. So here we are, Thursday, June 29th, and we're just getting it done. But hopefully it's going to get out today, because we have some things that we want to say, that it's a date involved and whatnot. But what an amazing doctor. Mm-hmm. I wish every doctor, every psychiatrist was like him and his wife. And, it reminds me when I was speaking at the State House one time, and I brought 3 sheets with me of reasons people got put on psychiatric medication. And if you had a doctor like him, you wouldn't have been drugged, or he would have noticed you're sick from one drug, because the majority of the reasons people were put on was a reaction to an antibiotic, another drug, or they had I think some of the reasons, the birth control pill. A lot of girls start to get anxious on the pill. Some of them, they lost too much weight. They weren't losing enough weight. I'm trying to think. One had the flu too long, so she got put on a benzo. So there was a survey done years ago. So I had 3 pages of reason. In fact, if people want to listen to that episode of Medical Prescribers Listen to Me, I read off all the reasons people got put on drugs. And if you have psychiatrists like Josef and his wife, it wouldn't happen. They'd recognize what happened, the medical harm that's to come down the road. Even something like myself, after childbirth, something's wrong. I feel like I weigh 1,000 pounds. I had an infection. Nobody's picking up. It's all in my head. I got drugged for 10 years. I mean, he's good. He's good. Yeah, he was great. And, it'll take doctors like him leading the charge to kind of make a difference. I know, we try to do it with legislation and everything, but the truth is it kind of has to come from within in the end.
Yeah.
And so it'll be a doctor like him
or him that changes everything.
Right. I like that on the YouTube channel, he tries to put anything and everything out there for people to learn. So, yeah, he is getting booked. There's a waiting list to see him and his wife, and that you can go on, look at his YouTubes. They're really good. He's just interviewing people. I mean, we do everything audio-wise, but you can see and, watch them talking, and it gives you hope. So he's giving you answers. He's putting it all out there. I mean, which is amazing. I love that.
That's important to me, too, because anytime you see people that have a certain expertise, I'm always wondering how they gatekeep their information, and he doesn't at all. He puts everything out there for people because, I think you can hear it in the interview that he's empathetic to what these people are going through and wants to help.
Right. He's also still willing to learn from all the people that have been made sick. I like that.
Yeah, so I thought that was one of the most interesting things about the interview. When he wasn't sure about something, he said that's something I need to learn about it. And it's refreshing to hear from a doctor, just because, with like some of the health issues that I've had recently, it's like you go and you talk to a doctor and they tell you what something is, and then you tell them, well, that's not how I'm feeling. And they want to tell you how you feel, and then you kind of don't know where to go from there, where, it seems like he's willing to learn.
Yeah, I really like that. I mean, I hope everybody, goes to the channel and watch the videos. He's put them all out there. Not that I've seen them all, but I try to catch them from time to time. And they're good. I mean, some of them, when I go back and I'm listening to them, I'm like, oh, yep, that was me. So for somebody going through it, it's like, all right, this one's able to go back to work. They're not perfect, but, there's a lot of encouragement in them. And isn't that what we're all trying to do, is encourage and bring this problem to light?
Yeah.
So, yeah, and again, I hope we can have him back, because I still, when I looked at the list that night when we were doing it the other night, I still had so many things that I wanted to get involved in, because he does all the psychiatric drugs. We're mainly benzodiazepines. Yeah. But there was so many things, and, people with more of the protracted stuff going on, and that would be another whole show to talk about protracted issues.
Yeah, so. I think at some point we'll get to a follow-up with him, and I won't be surprised if he has answers for some of the things that
because he's learning.
He wasn't able to answer tonight, but...
And I loved, when we talked about the black brain, again, and I said there were 3 of the young women suffering with it. Actually, there was a 4th, because then she's writing to me later on. They're all, don't know how to word it, but when one says black brain, they're like, yeah, that's how they understand it. And he gives his email address to contact him, because he wants to understand that more. That, to me, is a doctor really learning and caring, truly caring. So, yeah, he was awesome.
He was great, yeah.
Yeah, so... I want to get into a couple of other things here. So while we're on, because again, today is the 29th, and for anybody who hasn't seen As Prescribed yet, it is still playing with the Love Wins Film Festival until tomorrow, June 30th. But it is also going to be at the Melbourne Documentary Film Festival. You can find the link for ticket purchases on the asprescribedfilm.com site, or on the Melbourne Documentary Film Festival site. As Prescribed is going to stream from July 1st through the whole month until 200 tickets are sold. So As Prescribed receives no money for it. So, and they're glad that the festival does, because the cost to run a large festival is immense. So, and you know what? I want to read something just quickly, because my cousin, who's been trying to watch it, she sent me a text today. She finally saw it. So I'm going to read what she wrote, because... I talked to her yesterday when she was 3/4 of the way full, and she goes, don't tell me what happens to Scotty, and oh my gosh, your friend Paula, and blah, blah, blah. So she goes, don't tell me anything. I have to finish watching it. So today I get a text from her. She goes, I was afraid Scott was going to kill himself. I cried when the 2 brothers testified, but I'm so proud of you and Garrett for all that you have both done to make known the terrible life-changing results these drugs have done to so many people, and to testify as you did so many times to help make necessary changes to prevent the terrible side effects that so many have experienced. You are an amazing champion for the cause. It is an outstanding documentary. The doctor at the end is a criminal as far as I can see. Do no harm, as they say. He could care less. So that was from my cousin Kathy.
So it was nice to get that because she's been trying to watch it, and each time she's like, I couldn't get on, I couldn't do this. So, and she knows some people that are on it. And actually one person, he's in his 80s at this point, and I said to her, at this point, I would leave him alone. He's functioning, he's 80, it's just too much. So, I think that, I'm trying to get, some of my other cousins are trying to watch it.
Slowly but surely.
Slowly but surely. So anyway, that's that.
On that kind of note, people that I've worked with in the State House on, on the documentary, that knew the documentary was going on, worked on the bill. It took seeing the documentary to understand what the bill was really all about. Because, I think unless you have somebody in your life that's gone through it, it's hard to kind of understand it. And you kind of put it, what people always kind of bring up to me is the opioid epidemic. So that's kind of the only way they understand it. Like, oh, it's like opioids.
Only worse.
So, the documentary is important in helping people understand what's actually going on. And so I think, too, we're hoping to show as prescribed at the State House either this month, like in July, or once we come back into session in the fall, because August is kind of a dead month as far as, actual reps and senators being in the building.
Because that's something Holly's wanted, and so that's great.
Yeah, and so I think the documentary being shown in there and being shown directly to legislators and policymakers.
I mean, how would it be done? Like in a room where they all go see it, or it'd be via Zoom?
We have a couple of auditoriums. Probably wouldn't be in there. We have something called a reading room where we'll do press conferences and things like that. But they have a couple of really big TVs in there, and you can fit almost 200 people in there if you want to.
Would they allow constituents to come too, I wonder?
It's a public building, so anybody could probably walk in, but you would from our office, we would invite every rep and senator, so 200 legislators to come and watch.
And we have a new representative from our area. We have a new rep, so I would make sure that I talked to him beforehand and that he's there. I mean, he's this area now, so he's the new kid on the block, so he should be there.
Yeah.
So, all right. Well, I hope everybody really enjoys that interview. And we most likely are not going to do, you never know, but I don't think we're planning on doing another interview until probably September, because we said in the last one, Leanna was having her baby.
And she did.
And she did a lot earlier
You're
than...
officially a grandma.
Yeah. And so, they ended up taking the baby early because she had blood pressure issues. So they took the baby. And, that was quite interesting.
Yeah. Now we have little Izzy D.
Yeah, Isabella Dean. And, so she's a little itty-bitty, tiny little thing, who right now she's being a terrorist for her. So
and you're actually on your way there now.
I'm going there now. So a lot of the summer's going to be to help her so she can get some sleep. The baby's was perfect for a little while there, and now having a little bit of a hard time. So there's a lot of adjustments she's doing great. I have to say, Leanna from the C-section's recovering a lot better than we thought. She's breastfeeding, she's adjusting to that, and it's, a little hard. She needs help, know. So we're going to give her the help, and then my sister's coming for 3 weeks, so we need to enjoy the summer. We're going to enjoy the baby. We're going to enjoy when my sister's here. And
so the plan for right now would be to shut it down for the next 2 months, and then we'll be back in the fall.
Yeah, unless something big. We have so many lined up, and we just, you know what? After going through something like benzo withdrawal, it's time to put life first over this. So even interviews with Coheal, everything, it's going to be down to a minimum.
We've always said, if something important comes up and we really want to do a show, it really just takes me and you with a laptop in a closet with a bunch of old suits from the 70s to get a show done.
Yeah. All right. Well, as always, we appreciate all the people that listen. We appreciate the comments. Always like and subscribe to the podcast, to YouTube, since we're on both. The more
comments always help, so we know people are listening and enjoying.
Yep, and the more you like on YouTube, again, we all know I'm so bad technologically. It brings us up more. I think once we get to 1,000, it'll start really push out there more. So I don't know. Young James is the one who always tries to explain that to me.
He's our YouTube expert.
Yeah, he's the expert. Not that we really spend a lot of time. So again, we really appreciate it. All the comments, all the emails, and we hope you all, even for those that are struggling, there there is hope at the other side of this, and I never thought I would get there, and you will. So I hope you all have a good summer, and thank you for listening.